Thank you for being here, everyone. We'll get started with Lymphoma Insights shortly. We'll be using the Q&A feature today to ask Dr. Roschewski questions later in the program. Please feel free to submit questions anytime, and we'll get to as many as we can after the presentation. And just a reminder to use the Q&A feature rather than the chat. Welcome to Insights into Minimum Residual Disease with the Lymphoma Research Foundation. I'm Dana Bork, Associate Director of Stewardship here at LRF. I'm here today to answer questions and provide any technical assistance you might need. First, I'd like to introduce our host, Jeff Block. Jeff joins us today as a 17-year lymphoma survivor and is a champion for the lymphoma community, serving as Vice Chair and Treasurer of the Lymphoma Research Foundation's Board of Directors. Diagnosed in 2007 with follicular lymphoma, Jeff's lymphoma later transformed to diffuse large B-cell lymphoma in 2018. He was treated by a great team and today is a lymphoma thriver. We are fortunate to have him as a supporter within the lymphoma community and grateful to have him with us today. Thank you, Jeff. I'll turn the program over to you.
Thanks, Dana, and thank you to everybody for joining us today. As a survivor, I'm always eager to hear about upcoming new treatment options and diagnostic tools. We're excited to share how LRF is cultivating the future of cancer research, and I'm pleased to have the special opportunity to assist in today's program that focuses on minimum residual disease, or MRD. I've served on the board of the Lymphoma Research Foundation since 2019, and I'm pleased to help the organization that helped provide information and support during my journey. And the more I'm involved, the more grateful I am to the organization and donors who support the patient services and research, such as that which we will be hearing about today. Like finding a needle in a haystack, new MRD tests can detect a single cancer cell out of 1 billion normal cells, giving greater confidence in remission and enabling quicker follow-up treatment in case of recurrence. As with any rapidly evolving technology, however, it takes time, research, and collaboration to determine how best to use this powerful diagnostic tool. One of the Lymphoma Research Foundation's greatest strengths is its powerful convening power. The unique ability to bring together the brightest minds in cancer research from the best research institutions in the world. By providing this opportunity for researchers to share knowledge, LRF is leading the way to better treatments and cures. LRF did this on September 20th and 21st. We hosted a symposium to clarify the role of MRD testing in both clinical trials and in routine practice. Participants included leading academic oncologists, as well as representatives from the FDA, NIH, Centers for Medicare and Medicaid Services, and the pharmaceutical industry. These stakeholders engaged in 2 days of presentation and discussion that covered the state of MRD science and technology, current research findings and treatment implications, lessons from the pediatric setting, examples of MRD in clinical research, regulatory considerations, current knowledge gaps, and future directions. Dr. Roschewski played a leadership role during the symposium, moderating the initial panel on the state of science and technology, and we're excited he's with us today to provide a behind-the-scenes update. Dr. Mark Roschewski received his BA from the University of Notre Dame and his MD from the University of Nebraska Medical Center in Omaha. He completed internal medicine residency training while serving with the U.S. Army and completed his hematology oncology fellowship in 2009 at Walter Reed Army Medical Center. He served as the director of hematologic diseases there for 3 years before joining the NIH as a commissioned corps officer in the United States Public Health Service in 2013, and he retired as captain in 2023. Dr. Roschewski's current role is as a senior clinician in the Lymphoid Malignancies Branch with a clinical research focus on the biology and management of patients with both indolent and aggressive forms of non-Hodgkin's lymphoma, and a special research interest in the development of circulating tumor DNA in lymphoma. We welcome Dr. Roschewski to discuss how MRD diagnostic tools are changing the game and to share more about his work. Dr. Roschewski, I turn the program over to you.
Okay, well, thank you. I hope you can hear me. First of all, I want to thank the LRF for this opportunity, both Jeff and Dana for inviting me to be here. You know, the topic at hand, you know, these emerging tests that we want to use as measures of measurable residual disease, minimal residual disease, these are really, really important and timely concepts in lymphoma. And the reason I say that is because for a number of things, we haven't yet established these as tools that we can use in the clinic. Yet, you know, it's only a short period of time ago that I was a fellow discussing with my patients what's the right therapy, and most of the choices were chemotherapy, and maybe there were some new agents. But now what we're seeing is that as all of these newer therapies come along and newer combinations of therapies come along, the choices become much greater. The choices, there's more choices, but then there's a need to have a better understanding of how well each therapy works. And what I mean by that, and I'll show you some data, is as we then have the ability to enter remission or complete response in a greater number of patients, then we have to actually know a little bit more about complete response and what it means to really know what's happening in our patients. That's number one. You heard Jeff say at the beginning that this is an emerging field, and I think that's also very important. In other words, what I'm going to talk about today is where we are today, but these things are moving very quickly, and this is where the LRF comes in. So you heard the other thing you heard in the introduction is that, you know, there was a symposium held in September. There's been multiple different symposiums by various stakeholders that are discussing these issues because everybody recognizes that these are critical. And one of the things the LRF can do is bring together these various stakeholders from their perspective and then get the discussions going. And so it's an exciting time to think about this. And that's a long but important background to how I'm thinking about circulating tumor DNA as a measure of MRD in lymphoma. Okay, so let's get to it a little bit. So the first thing to sort of recognize is what problems do we think these blood tests can solve? So we then have to look at, well, what's the standard that we would want to improve upon? And what we're talking about most importantly is the response assessment, or the determination of how well a given therapy works. In lymphoma, this is very, very reliant on imaging scans. And the most important imaging scan that we have are these PET scans, FDG PET scans or PET CT scans. So this is the standard for which we know where the disease is before we start therapy. And it's the best test we have to determine if the patient enters a remission. So the end of therapy response assessment, that's what's critical. The problem with PET scans isn't that they're not excellent tests. The problem is they have limitations that are fundamental, that are not going to change. What I mean by that is for a 1 centimeter tumor to show up on your scan, that's 1 billion cancer cells. And so it's not possible for an imaging scan to measure down at the very, very low levels of 1 in a million or 1 to 10 million molecules. So it can't measure molecular disease. It's not possible for the test to do that. And the other problem with PET scans is they're very good at picking up a lot of different things, which means they're not specific for lymphoma. And so things that show up on a PET scan, oftentimes we as physicians and patients are trying to figure out if it really means that there's active lymphoma. Then the other thing that is potentially improved upon or replaced by these blood tests, and I won't talk about it as much, but it's important to recognize, is that this is a way we can actually get information of the tumor itself. So of course, the standard to do this is a tissue biopsy where we stick a needle into a mass and we come away, that's how we diagnose cancer, that's how we diagnose lymphoma. It's also how we get all these prognostic markers, these prognostic biomarkers, and it's how we determine if the disease actually comes back. In other words, after therapy is over, if a PET scan is positive, since it doesn't always mean the patient has lymphoma, we have to do additional tests like biopsies to actually figure out if the patient needs additional therapy. But this is difficult across all situations, and we can't always do biopsies. Every biopsy has some risk. And the other problem is when you're putting a needle into one area of the tumor and there's areas in other sites of the body, it doesn't give you all the information, all the genetic information you want. And different sites of the body may actually have different information. So when we're talking about circulating tumor DNA, first it's important to define this. So this, of course, is the bloodstream. You can see multiple different molecules are in this depicted blood vessel. And most of the DNA that's floating around, so this is free-floating DNA in the bloodstream. It's not inside cells. Most of this doesn't come from the tumor. So this is what we call cell-free DNA. So many of this is derived from normal tissues. But when we have a patient with cancer, what we're interested in is that fraction of the cell-free DNA that comes from the tumor. And that's what circulating tumor DNA refers to. So at the beginning of therapy, that might be a large amount of the cell-free DNA. But at the end of therapy, this is like finding a needle in a haystack, as Jeff said, maybe 1 in a million molecules. But you want to be able to have a test that can distinguish between the cell-free DNA that comes from the tumor and that which is normal. And that's what this process represents. Of course, this is less invasive than a biopsy. It can be taken from the plasma. You can extract the DNA, and you can do this in a lab to determine whether or not the patient has active disease. And so the potential advantages are the specificity and the limit of detection. So this can detect disease that's present orders of magnitude lower than imaging scans. And when we want to do it as not just presence or absence, we can actually use it as a quantitative measure. We can have a quantitative measure that correlates quite strongly with the total amount of tumor burden. These things change quite quickly. So in the middle of therapy, the levels of ctDNA will change within a few hours. And this is, of course, a much easier thing to do serial testing on, as opposed to imaging tests, which tend to come at landmarks. And as I just sort of hinted, you can get other information of the tumor and the genetics of the tumor, which may help you in a research setting or potentially select individual targeted therapies. The problem in lymphoma is not a single thing, right? So there's at least 90 different subtypes, maybe 95. And even within each of these subtypes, they're very different. So it's very heterogeneous. The part of the slide I want you to look at is this up here, this diverse mutational profile. What does that mean? Well, we can't just look for one thing. So in other diseases such as CML, chronic myelogenous leukemia, we're looking for pretty much one thing that defines the disease. But in lymphoma, there's multiple different mutations, and there's multiple different mutations across lymphoma. So we have this low fractional abundance. When we're looking for a needle in a haystack, if we have one thing to look for, it's much easier. You could use something like PCR or some of these other methods. They're looking for a singular thing. But here, if we're looking for something that has different mutations across different patients, you have to have a broader look, and that can sometimes limit the depth of detection. These have been some of the ways we've been thinking about the challenges that we're looking to overcome, and we're getting there. So a couple of things that have been established. Now, what I'm going to show you is a few data slides as they relate to diffuse large B-cell lymphoma. Some, but not all of these things translate to other lymphoma types, and we can get at that a little bit more in the discussion. But at this point, it's well established that the level of circulating tumor DNA, that's what's measured over here on the left, just the amount that you have at the time you're diagnosed is indeed prognostic. And it's more prognostic than other features. That's what's shown over here, but this multivariate analysis. So the levels of circulating tumor DNA give us more information than simply the total metabolic tumor volume. That's what TMTV means. That's a PET scan measurement, or even the nature of the disease. And this has been shown in a number of different settings as a measure of understanding who might be the highest risk to not get a cure with their therapy in large cell lymphoma. We also have seen, and this was commented on, that when things change quickly, you might be able to have an understanding of the prognosis in the middle of therapy before you get to the end of therapy. So here, what this is showing you is after just 2 cycles of chemotherapy, you can see that when patients have achieved a certain threshold, in this case, it's considered an early molecular response, which is a couple log reduction in the circulating tumor DNA. Most of these patients have a long durable remission, and those patients that don't hit that landmark after 2 cycles have a much worse prognosis. And this is being studied in this context to determine if we can use changes in the middle of therapy to actually refine our therapy based on early response. Now, this slide shows us how imperfect PET scans are. If you look at the end of therapy, so now this is getting to the determination of, is my patient truly in remission? Am I, the patient, truly in remission? And you can see here that if the patient achieves a complete response by PET scan, that they do very well. And they certainly do better than if they don't achieve a PET scan. This is taken from a randomized study. This is over 1,200 patients. You can see that 88% of the time, the patients achieve a remission by PET scan. The problem is that there's still 15 to 20% of those patients who believe that they're in remission that will ultimately relapse. And the positive predictive value, meaning if my test is positive at the end of therapy, if it says that PET is positive, less than half the time does the patient actually have lymphoma. Frequently, these are false positives, representing a worry for a patient that doesn't need to be a worry because they're actually truly in remission. So the tests have limitations in both directions. And even the guidelines themselves recognize this. So this was the last paper that was published on the way we use our response criteria, and Bruce Chesson told us. He said, look, if you're going to give therapy based on the PET scan, you should either biopsy it or follow it up, because a single PET scan by itself doesn't give you the answers you want. And our guidelines say the same thing. If we're at the end of therapy, if it looks like we have not achieved remission down here, a Deauville 4 or 5, which means it's positive, you should repeat the biopsy before you go on to second-line therapy. And this is what this is reflected here, that a single PET scan that's positive should not be enough information to go on to second-line therapy because of the limitations. And so in a recent data set that I'll show you a couple slides on here before we get to the questions, we asked this question of, but how often does this happen? How often are we needing to do these additional procedures? I thought the end of therapy PET scan was all I needed. And conversely, how many times are patients whisked off to receive salvage therapy, but we haven't proven they have disease, potentially over-treating a group of patients that are actually in remission? So I told you that these assays are undergoing development, and these sort of first-generation assays, such as clonoSEQ and CAPSEQ, really couldn't get at the end of therapy. They weren't sensitive enough to tell us if the patients were going to relapse. You can see here, this is just taken at the end of therapy. The clinical sensitivity, which means of the patients that are going to relapse, can I detect it with a single blood test? It was much less than 50%. So there wasn't much utility in using these as measures of MRD. But things have changed. And what has really changed in the technology is the emergence of these assays that I now describe as ultra sensitive. So they have an improved analytical sensitivity. So they can measure much lower levels and be certain the disease is actually from the tumor and not from non-tumor sources. And this is an example of one of those assays called phased-seq. So when it compares to CAPSEQ, there's a 500 times improvement on reducing the error. So that's what these assays have to do. They have to be certain when they tell us, or as certain as they can be, that what they're measuring is actually from the tumor and not from a non-tumor source. So they reduce the background error rate, and now these newer assays can actually improve the detection all the way down to 1 in 10 million molecules, which then improves the sensitivity to as low as 1 times 10 to the -6, or even potentially lower. What we just showed this week was that also translates to improved prognostic ability. So what you're seeing here in large cell lymphoma, this was taken from a study that we are actively doing right now at the NCI. As you can see, there was 46 patients on the study, and 14 of them had remaining detectable ctDNA after just 2 cycles, and those patients worse than those patients that had already gotten undetectable levels. So if you were one of these patients and you achieved an undetectable ctDNA after only 2 cycles, again, that's 2/3 of the patients, the 2-year progression-free survival was 97%. So most of those patients were cured, and in most cases, we knew it as early as 2 cycles if we had had this test available to us. We didn't know it on the study, because we're doing this in a retrospective way. And we took those same patients and we said, well, what about their PET scan, and how did that predict outcomes? This is an ongoing study we have. We had 54 patients that we looked at. They had a PET scan available, they had a blood test available, and we looked backwards at what happened to them. And you can see that achieving a PET scan remission is actually very important, as we already knew. Meaning if you get a PET scan CR, this is the blue line, then the 2-year progression-free survival was 90%, and the hazard ratio of either getting progression or death was 3.2 times higher if you actually had detectable disease by PET scan. But strikingly, if we looked at the same time points in the same patients, the circulating tumor DNA was more prognostic. And what you can see here is that virtually every patient who tested negative at the end of therapy for ctDNA neither progressed or died. In fact, the one patient who that wasn't the case died while in remission. And of course, the blood test wouldn't predict death from non-lymphoma causes. And patients that were positive at the end of therapy had a much worse prognosis, and this was 36 times more likely to predict progression or death than the background risk. And the last sort of slide I want to go into that we presented was, so what is happening now to our patients is we're doing all these other tests beyond just a single PET scan to figure out if they're in remission. And we looked at this. We had the nuclear medicine doctors read our scans, blinded to outcomes. And what they told us was that 14 of these are positive and 40 are negative. So that we already knew what happened to the patients. And we said, okay, so 9 of these patients had to undergo either a biopsy of that PET positive region or a follow-up PET scan. But only one time did that turn out to have lymphoma. The other patients didn't have lymphoma and were actually in remission, even though the PET scan suggested otherwise. If we look at the patients that tested MRD negative or positive, and again, we didn't know the results, what we see is that half the time they actually tested negative. And when they tested negative, none of those patients actually progressed. Whereas in the positive, only 2 of these patients progressed. One was diagnosed with a second cancer and she died of something else, of AML, and 4 patients were still following that may actually progress at some point. And if we look at this patients that test negative for MRD, we haven't had a single patient on this study who actually progressed after testing negative for circulating tumor DNA. And interestingly, 4 patients that were negative on their PET scan, they progressed and they were all positive for MRD, suggesting that, again, this might be a better way of knowing which patients are actually in remission. And so to summarize this, very few patients progressed. No patient progressed with undetectable MRD. Very few patients who underwent additional procedures actually had active lymphoma, and only a small number of patients that had a positive PET scan ever progressed. Now, the LRF, I just want to comment, I think the dates are wrong, but they played a really key role in not only starting this with one symposium, but then agreeing that we want to have a continuous discussion of this with repeated meetings. And I think one of the things we've learned from the symposium is that this lymphoma is farther behind than other malignancies such as CLL, myeloma, and CML. These diseases are already using these types of tests to make clinical decisions. We haven't gotten there yet. And one of the problems is we have unique challenges because we have a lot of different types of lymphoma. It's not a singular disease. And this might be a very different discussion in a patient with follicular lymphoma or mantle cell lymphoma than with diffuse large B-cell lymphoma about what it means. So we did identify knowledge gaps, and we're working on a roadmap moving forward to eventually address all different lymphoma subtypes. And I think the key phrase that we came away with as a field is not to let perfect be the enemy of the good. Certainly, there are a lot of additional questions that we just don't have the answer to yet, but we really want to integrate MRD at least into all clinical trials across lymphoma. The one that is probably the closest to becoming actionable in the clinic is actually diffuse large B-cell lymphoma. And it's useful to think about that because that is a curative disease. So being in remission is required, and having the best test to tell us who's in remission is only rational. But then, of course, we want to study it across other lymphoma subtypes and learn how we can help all these different subtypes and think about it even as a liquid biopsy. So this MRD working consortium has been established. We plan on continuing to have these discussions with patients and other stakeholders and have periodic updates. Here's my contact information for any additional questions. And in addition to that, I'm happy to stay here and listen to what your thoughts are and questions immediately. Thank you.
Okay. Thank you, Dr. Roschewski. That's terrific information, and we're happy that you were able to provide that for us today. That's terrific. I do have I've got some questions from some of the folks, so let me jump right in. In terms of the study that you were showing, where was it? It looks like you're prognosticating about the people that had no MRD after 2 cycles, but at this point, we're not stopping people, are we? You haven't tested whether we stop them after the 2, or are you?
So not on that study. So that study, we were looking backwards. So we already knew what happened, and we were addressing this question of if it's truly prognostic. We've known for a while that it probably is. And so there are studies that are being planned, as well as those that will open soon, that will actually give less therapy. So that's one of the goals of these blood tests. We've known for a long time that if you're trying to cure a patient with diffuse large B-cell lymphoma, she often doesn't need 6 cycles. We know that that's true, but we just don't know when and how we can safely stop therapy. So those things are going to be asked now. And so at this point, we wouldn't recommend that, but we're not too far off from having that be the case.
Okay, great. And then you also talked about DLBCL being, what you guys were testing. Are other people in clinical trials testing for other types of lymphoma, given how many there are?
Virtually every single presentation at ASH this year with lymphoma had some measure of MRD. So as a research tool, everybody's interested in it. We're looking at it at the beginning of therapy, in the middle of therapy, at the end of therapy. There have even been some abstracts looking at it as a surveillance tool. So it's really versatile, being used in a number of different ways. It's also true that there's different assays being used. So we are in the process of kind of harmonizing these results and trying to understand, when you're asking questions at various time points, what are the specifications of the test that need to be in place before you can believe and act on the results. So we're still sort of sorting that out, but there's no doubt that there's interest across all of these lymphomas.
Okay, great. A question is that, and I'll just read it verbatim. I'm very intrigued with MRD, but I talked with my oncologist, and he's mixed opinion on it. For example, if it's positive, you worry, and if there's likely nothing you can do about it till it progresses. But if it's negative, then you still need to keep your guard up because there's no cure for FL. And since it's speculated that it's genes based, then MRD might be negative, but it might still reoccur.
Okay, so that's a question specific for follicular lymphoma. So it's true that we don't yet have a test that's available that we can use to make clinical decisions. But at least in diffuse large B-cell lymphoma, when we've looked with this recent assay, when the test is negative, none of those patients have progressed. So at this point, what we can say is in diffuse large B-cell lymphoma, it's the best test to tell us that we're in remission. It's also true that we don't yet know if we should be treating this MRD only situation. So that would be a paradigm change for treating doctors, meaning we don't treat patients that have disease in the blood that we can't see on a scan. That hasn't happened yet in lymphoma. It has happened, though, in other cancers. So we do have this approach in, for example, acute lymphocytic leukemia, ALL. We do treat on the basis of MRD. So there's a world in which we could prove that that has a benefit and actually show that earlier treatment, for example, improves outcomes before it would have shown up on a scan. We haven't been able to show that yet because the tests are too new and those tests and those clinical studies haven't been done. So your doctor's right that we don't yet know how to do it, but it's moving quickly to this direction. And I think all of us who treat patients should recognize that this is almost certainly going to be the way that we monitor patients in the very near future.
Great, thank you very much. How important is this in terms of a surrogate endpoint? Do you expect this to shorten the timeline for new treatment options from clinical trials to FDA approval?
That is the ultimate goal, and I'm glad that got brought up. So there are clear guidelines from the FDA about what qualifies as a surrogate endpoint. So what that means is, can you tell earlier if patients are going to live longer, right? So when patients live for very long times after therapy, you don't want to wait 10 or 15 years to prove that the therapy is effective before we get it back out to patients. So that is certainly a goal. Now, one of the problems is to establish true surrogacy, you have to have multiple different data sets to show that that works. So the standard typically takes 7 to 10 randomized clinical trials that all show the same thing, all with the same MRD test. So you kind of have to imagine a world in which we get there over time. What can be tested now is these things being used as sort of a key secondary endpoint. So within the context of clinical trials, we should be able to continue to show that, yes, the patients that test negative for MRD actually have a better outcome than those that don't. And so it's sort of, these answers only come with lots of data. And so we're trying to, as a field, try to build that data so that we can make this case. But ultimately, absolutely, we want this to be a way to get treatments to patients sooner, for sure.
And if someone wants to ask their doctor if MRD testing can be helpful for them, first of all, is it available outside of clinical trials? And then if so, what are a few things to keep in mind?
So this is where the rubber meets the road right now. So the assay from Adaptive, the clonoSEQ assay, it is reimbursed by CMS. So for patients that have diffuse large B-cell lymphoma, they can get that assay done, and the doctor can go on their website and see the process. It requires both the original tissue, the original biopsy, and then a blood specimen, but that can actually be done. It's not widely available though, and certainly this phased seq that I was showing you isn't yet. That particular company has a CLIA certified assay, and they're working towards making it more available. But these things always, the leading edge of medicine, the things that are sort of the most exciting and emerging, it takes time before it gets out to the masses. And some of that has to do with just data alone, and the other has to do with the ability to turn things around in a quick way to get it to a doctor to make a decision. Of course, PET scans are available right away, and we know how to use them. These tests here aren't nearly as immediately actionable as we want them to be, but that's all being worked on.
Okay, let me hold on. I'm looking again here. We're talking about MRD, but is kind of, just to kind of take it away for a second, one question was, what's next after MRD testing? Is there something even newer out there in terms of diagnostics?
So as diagnostics, okay, so diagnostics, if we're talking about like determining if a patient has cancer or not cancer, then what I would point out is there's different types of blood tests that are being tested. So this would be an example of a patient that we don't, or a person, we don't know they have cancer. And some tests like this that look at something different than circulating tumor DNA, they're looking at different than mutational profile. They're looking at the methylation profile, and they're using whole genome sequencing. And this is a project known as GRAIL. This was published recently looking for if we could identify cancer, different types of cancer, in patients who we thought were otherwise healthy. So that's more of a screening test, more a diagnostic screening test. And that looked like that could show it in some cases, but it was relatively low just because the incidence of cancer is low. What I'm talking about is tests that are looking at specific mutations when we already know someone has lymphoma. So that's the difference. But when I showed you that blood vessel there, and I showed you there's different things, there's cells in here, there's DNA in here, there's all these different things in the blood. There's different questions that could be asked based on different assays, all getting at this point of diagnosis. And it's ongoing across all cancers too. I'm showing you lymphoma, but these efforts are ongoing across virtually every cancer type there is.
Okay, here I got a quick question. The terminology, is there a difference between minimal residual disease and measurable residual disease?
Technically, no. It means the same thing, but we have realized that MRD, minimal residual disease, is a little bit of a confusing term because it doesn't really tell us what technology is being used. It doesn't tell us when we're doing it. It suggests there has to be a minimum amount, but what if it's negative? So measurable just becomes an easy thing to think about if it's there or not. And it helps us understand certain concepts, like if our test is undetectable, that doesn't always mean there's nothing there. It just means it could be the limitation of the test itself. And so for assays or tests that have less sensitivity, their undetectable may actually not be negative. And if you use a more sensitive test, you could find it. So the term is being used more often that it's measurable residual disease, meaning can it actually be measured by that assay being used, as opposed to minimal residual disease. But they essentially are just, they basically mean the same thing. They're just the context can be different.
And let's see, how accessible is the instrumentation for running ctDNA testing? What type of instrumentation is required?
Well, right now, the best tests all have some level of central processing. So the best tests available to us for lymphoma anyway can't be done at your local hospital. They have to be sent locally or centrally for the bioinformatics and then the biospecimen processing. Someday, though, the vision would be to have things more accessible to include at other diagnostic labs and these types of things. And so this is sort of a cascade of events down the road that we see happening, but it's not yet available.
What, I'm trying to think here. What do you see as, I know this is asking a lot for prognostication, but when do you see this being able to be used more widely?
So for diffuse large B-cell lymphoma, I think we're probably getting quite close. The data looks good. It's not yet published. It needs to be published, and certain guidelines have to change. Potentially even an update to the response criteria, which was discussed this year in a meeting in Lugano, Switzerland. So the way we talk about the response criteria, which typically get updated every 7 to 10 years, is we had this discussion about whether or not it's if there's enough data to implement that in our formal assessments of response. And there's still ongoing discussions about whether that is true or if we have to wait for more data. I think some of those things, some of those important discussions with the key stakeholders, and I would identify them as, the academics who write the response criteria, industry folks who collect these data sets, regulators who interpret these data. Those discussions are ongoing now about what steps have to make before it's accessible. It almost certainly won't be as accessible as quickly as I want it to be, because of the way things work and the fact that we're talking about something that is new. It's new to think about a blood test, at least in lymphoma, to guide therapy. And so it's going to take us a few years before this is actually routinely used. My view, though, is that in 5 or 10 years, we're going to be using this widely.
Do you think that will include the indolent lymphomas like follicular? We're getting a lot of questions as well.
Absolutely, I do, because what's happening in follicular lymphoma, which is amazing, is these therapies are getting so good that when you put them together in combinations, we're seeing complete response rates of over 90%, even in the relapse setting. That's completely unprecedented. So that means that the PET scan is negative 90% of the time. Well, we don't think all those patients have been cured. So the importance then of having an additional test to actually understand, well, who's truly has the best prognosis amongst these 90% becomes much more important. When it was chemotherapy as our best test, the complete response rates were 30 to 50%. So there wasn't as much need to have another test to kind of adjudicate these results because most people still had things you could see on PET scan. But that's changing. And the other thing that's happening for indolent lymphoma is our treatments can be quite long. Even some of the really good therapy can be a year or 2 or 3 years long. But if we were to know that we could stop therapy safely after a shorter period of time, say 3 months or 6 months, and if we were to know who those patients are and who could safely stop therapy early to enjoy some time without being on therapy, that becomes a major benefit to the patients and our healthcare system. just not having to be on therapy. So this is the best way to rationally decide those things. What we do now is we decide based on just, published regimen durations of a year. And in most cases, patients probably don't need a year of therapy to get the same benefit.
Okay, thank you. You spoke a little bit about clinical trial involvement with MRD, and when I was sitting in and on our grant reviews this year, I saw quite a few proposals involving MRD. What would you say to someone who's considering being involved in a clinical trial?
Just in clinical trials in general? Well, right now,
Yes.
It's difficult to put enough emphasis on the fact that the patients that get treated on clinical trials right now almost certainly are getting better therapy than what's available standardly. And the reason is because there's been a emergence of medicines that are so effective that's completely unprecedented across all of oncology. So it used to be, and this was true even when I was beginning my fellowship, that to go on a clinical trial, what we did was we tried everything we could think of. And then when it stopped working, we said, well, maybe we should try a clinical trial, because the benefit to the patient was maybe only in solid tumors, maybe it was 5%, maybe 10% of those patients benefited. Now we're seeing patients that go on early phase studies. So we do a lot of phase 1, phase 2 studies. We have patients that will come on our study and we'll do phase 1 or phase 2, and 80 or 90 or higher percentage of those patients are clearly benefiting from that new therapy. And sometimes what happens is they're taking a new therapy that never actually becomes FDA approved, which means they had one more shot on goal that they wouldn't have gotten with standard therapies. So I do think that in many cases, clinical trials are often the best therapy a patient could try. Now, one of the challenges for our patients is there's so many clinical trials. If that becomes the challenge, is how do I choose between these various clinical trials? And that becomes more difficult. That's where you want to talk to your doctor. But certainly, we're living in a world in which the accessibility to these things, at least for many patients, is completely without precedent.
Thank you. As we discussed earlier, you helped lead LRF's MRD symposium this past September. There were many researchers representing the best institutions, and it's a unique and important contribution to the cancer research community. LRF's uniquely positioned to bring all these different people together. Can you tell us a little bit more about why this is special and why it's important?
Yeah, I can, because I work in the government. I work at the NCI, and a lot of people are interested in, well, what does the FDA think? And as a government organization, we can set up symposiums and we can discuss with the FDA certain things like endpoints, and that actually happened in October. But there's restrictions on whether we can invite all the stakeholders. So we don't, because of certain rules and concerns about conflicts of interest, then we don't get to participate in the same room and discussion with industry or even with patients. One of the things that the LRF can do is bring all those stakeholders together, and it's a very unique power. And when the LRF is talking to us, we all say yes. I think every single person who I could think of that has been working on circulating tumor DNA said yes to that meeting, including flying in from all over the country. And these are academics. And then there was a number of industry partners that were there. The FDA was there, and even the CMS, the Medicaid payers were there. And we all had various discussions, and we all didn't see the world from the same way. So to be able to bring different people together, they're all looking at it from a different perspective, all with an interest, but a different type of interest. That's really where the strength of the LRF was on display.
Great, thank you. You also recently returned from the annual ASH conference, the American Society of Hematology meeting. Any highlights there that you saw, either MRD or anything else?
Well, we presented the data I showed you. There was a lot of discussion about MRD. I think this was an impactful presentation that spurred a lot of conversations, and a lot of conversations that happened after the meeting. Across lymphoma, though, I think I would just sort of go back to my point about these clinical trials. We are really seeing an unprecedented time of the number of different trials in which patients are getting significant benefit from the therapy. What we're starting to see is different combinations. We presented a particular combination of a regimen called Viper that we've been studying, and we were showing that maybe 4 out of 10 of our patients with relapsed large cell lymphoma were cured, and they only had 6 cycles of therapy and they stopped. So that's one more way that patients that have diffuse large B-cell lymphoma, if they happen to relapse, can actually achieve cure. That's not something we've seen before. And we were seeing very similar things in mantle cell lymphoma, even central nervous system lymphoma. With some of these new medicines and new combinations, we were seeing sort of unprecedented complete response rates. So what we're learning in the clinical realm is how to put all these different drugs together in a safe way to try to get these deep, durable remissions for our patients. So it's kind of the main theme is that almost with each and every year, we learn this more and more about how to put this together in a thoughtful way for our patients.
Thank you. It's just a personal observation. I've been on the board since 2019, and obviously having been involved with lymphoma for 17 years or something like that, I've been paying attention and watching, and it seems to me that there's just an acceleration of new viable opportunities and options. It just seems remarkable.
I've never seen anything like it, and I mean, and lymphoma probably has some of the greatest advances. So I think that's absolutely true. What actually becomes the challenge now, particularly for maybe oncologists that don't focus on lymphoma, is how do we choose between them? So what we don't really have is predictive biomarkers. So that means having a blood test or a feature of the cancer that tells you which therapy to select. That's where some of the other aspects of circulating tumor DNA may come into play. In other words, if there's a mutation that predicts response to targeted therapy, you can actually get that information from the blood. And I think we're going to need more of these biomarkers, because at this point, we're really just selecting from so many choices. It can be almost like reading a menu in not your native language. It's overwhelming because there's so many different options. But that's a fun challenge to have.
It's probably more fun in an academic institution of the NIH than it is for a general oncologist who.
I think that's absolutely true. I can't imagine how challenging it. We try to be available to help answer these questions, but it has to be tough.
And we also, as at the LRF, are there to help them. We've got lots of education for doctors as well, for the community doctors. So, question here: how likely will single cell genomics be used in the future to determine the best treatment for individual patients? Is there work at the NCI using this technology to be more prescriptive? I guess that's what you're talking about, prescriptive for treatments decisions.
Yeah. So right now, the biggest advantage of single cell genomics is to show us in details how heterogeneous some of these tumors are. And maybe we can identify certain subtypes of individual immune cells that predict resistance. So a good example is when we talk about, the amount of T cells in a tumor, these single cell genomics are showing us, the differences about the types of T cells that are in that tumor bed. That helps us understand how challenging cancer is, but it also helps maybe identify a novel target. You say, okay, I can't just take out the T cells. I got to take out this type of T cell if I'm going to overcome resistance. That's really where the field is now. I don't think it's specifically necessarily going to be a translational tool to select therapy, at least not right now. But it's possible that it is in the future. But I think it's a little more technical right now to think about it like that.
Great. I've got a question here about you. When you were discussing ASH, you mentioned MCL findings. Could you provide a brief additional information or insights in that for somebody to go look a little bit more about it?
For sure. So last year at ASH in 2022, what we saw was that when you use these novel agents, in this case, it was ibrutinib, and you start that early as the first treatment, there wasn't much advantage, if any, for doing a transplant on top of that. That was very, very novel. Before, when we were treating patients with mantle cell lymphoma, we thought that we needed to give very intensive therapy in order to get durable remissions. But this was showing us that we don't even need that. So that's combining with chemotherapy. And of course, chemotherapy has been the standard for a long time. What we're seeing now in mantle cell lymphoma is that we're using combinations of these targeted agents, sometimes combining with chemotherapy, but in other situations, combining with other novel agents. So now, completely chemotherapy-free regimens, and we're seeing that we've had a number of abstracts using 3 drugs, and now some using 4 drugs. We have a regimen that uses 5 drugs, and they're all sort of showing us the same thing, which is that instead of complete response rates less than 50%, we're seeing the complete response rates climb into the 70, 80, 90. I even saw one almost 100% of patients that achieved a complete response. So that's interesting. And then it just brings to bear some of these issues as far as, well, how long do we give therapy? And do I need all the drugs? And can I safely stop? And so all of those things have yet to be answered, because we're only now seeing how active and safe they are when we combine them.
Okay, great, thanks. We are running out of time, so I'll just kind of ask you one last question. What would you say to someone who might be considering financially supporting the Lymphoma Research Foundation?
I think it's a great use of funds. I think that there are so many things that the LRF does. There's so many different types of lymphoma. It's overwhelming for us physicians to try to give our patients enough information. They have access to the information. All of our patients have access to it if they can get to it. So how does one sort through all that? Having a partner, a collaborator like the LRF actually help us with this, or help educate other physicians, it just increasingly has a central role. People know about it. It has a name. They know they can trust the information. We live in a world in which we're not sure what we can trust. Can we trust what's on the internet? So having these types of entities that continue to work like this, and I'll tell you, they really have a good knack for what's the most important thing to be studying in lymphoma. There's a lot of things to discuss, but they do have a knack for picking out the best ones. So I think it's a great organization, and I would encourage you to support any way you can, time or money.
Thank you, Dr. Roschewski. Dr. Roschewski put on his email address on a slide. Mine isn't up there, but it's really easy. It's jblock@lymphoma.org. If you have any questions for me, please feel free. And then I'll kick it back to Dana to close things up.
Yeah, thank you so much, Jeff. Thank you so much, Dr. Roschewski. I'll give you another number as well. So if anyone has any lymphoma-related questions about anything that was discussed today, or if you're in the position of choosing a next treatment or thinking about options, our helpline is an outstanding resource. You can reach them at 800-500-9976 or at helpline@lymphoma.org. You can also just email me or call, and I'll get you in touch with the right people as well. So thank you so much, everyone. That's all the time we have for today. As you could hear, it's really an exciting time in the world of cancer research. Dr. Roschewski, thank you for providing a behind-the-scenes look at LRF's important role in all of this exciting progress that's being made. All of you, thank you for not only attending today's event, but also for your investment in the lymphoma community. You make this promising research possible. I want to thank Jeff and Dr. Roschewski for finding time in their busy schedules to provide this valuable update. Each of you will receive a recording of this webinar, as well as links to LRF's website that features news and updates regarding LRF researchers and all of the exciting progress going on. This is also a great opportunity to provide feedback or ask additional questions we were not able to answer today. Happy holidays, everyone. Stay safe and healthy, and thank you for joining us. Have a great afternoon.
Take care.